Ladies and gentlemen, now that we've heard from the ministry, it's good again to invite good people onto the stage to discuss how it again looks in practical life. We have an audit manager, Rauno Vinni, and a founding partner at HealthFounders, Erki Mölder, joining us. And Rauno also gets a microphone, then we're ready to go. Oh, we have a handheld. Right. So, Erki, do we actually know where Estonian healthcare money goes to? And how do we understand this today?
Yeah, thank you very much, and thank you for the organizers to inviting me here to share the experience and my ideas on the topic. So I knew that you are going to ask that, so I'm going to ask the technical team to put a couple of slides on the screen. I'm going to guide you through the way how I see it. It's a busy slide. Some of you have seen it. Basically, the money goes into 3 different areas in the healthcare. The green one is related to injuries. The orange one is related to infectious diseases, and the blue one is related to lifestyle diseases or non-communicable diseases. And the way how you should read this is that the size of the rectangle shows how much the money goes there, and the intensity of the cover shows the growth. And what you see here is the snapshot of 1990, where the money goes. And this is the global way. And now, 35 years forward, let's see how this looks in 2021. Okay? So what you see is kind of the huge trend towards the blue. And this is due to the technology. This is due to the technology that keeps us alive. This is due to the technology that doesn't allow us to die, not healthy, but aging population. And you see that everything related to blue is kind of growing fast. And if we go now to the Estonian situation, then it is a little bit similar, not completely. Of course, first of all, the statistics of Estonia in 1990, maybe not something that you should look into and trust too much. But believe me, if you even kind of move 3 years or 5 years further, it looks very much the same. And if you look now at 2021 in Estonia, you see how much the costs of non-communicable diseases is growing compared to the other ways. So I think we know where the money goes, but I think that we don't really appreciate that the health in this blue area is not generated in the hospitals, if I may use this term. This health is not generated by the doctors. This health is generated by ourselves, by hundreds of small, tiny decisions we make every day.
And that we will again be able to make when we leave this conference and go for the snacks.
Yeah, or walk home, or take 2 glasses of wine or 3 glasses of wine.
I plan to get some snacks and perhaps walk home after a lot of convincing from this stage.
Yeah. And by the way, whatever country you look, kind of the trend looks the same. Even Africa, even Asia, even whatever country you take, kind of the trend is the similar.
Or perhaps I won't have snacks, now that you mention it. Now, Rauno, you're in the State Audit Office. How much of this data is actually dictating our policy in the state, where we put our money, how we design our healthcare policy? Is this a screenshot that all the policymakers constantly look at and try to understand how to diminish that blue part, or at least make it smaller?
I think in broad terms, do you hear me? Okay. I think that in broad terms, the policymakers do know that the picture is as it shows. but one thing is knowing and the other thing is doing. I guess that one character of Estonian policymaking in healthcare is that we have quite adequate big goals, like accelerating the rate of healthy years and so on. But the problem is that micro-level activities are not well connected to this big vision of where society should go in health. And we have meso-level goals. We have lots of things going on micro-level. We have treatment guidelines and so on. But we have a lot of questions about how the policy is made on meso-level, meaning that how ministry and also health board and health insurance fund and so on are implementing the policies that are well crafted into the nice development plans. So there is a disconnection, I think, and this is something that could be better in Estonia.
Erki, could we also measure or model the economic impact if, let's say, people live longer, healthier, and stay productive for more years? Do you have a visualization of that somewhere as well?
In my mind.
In your mind, okay. How do we get that from your mind to the policymaker's mind, is then the question.
This is interesting because I come from the world of technology, and when you look at adopting any technology in the healthcare, there is a technological element, but there is a clinical proof element, and then there is a health technology assessment element. So there are frameworks, actually, if you want to bring something new to the market, that you have to jump through the loops, and proving the efficiency of a solution is actually one part of that. Now, the problem for Estonia is that it's a country, but it's not a market. So me as the investor, I'm pushing the companies out from here because, yes, you can prove that something works in Estonia, but if you want to get my money as the venture capitalist, you have to scale. You cannot do it here. So the challenge for Estonia is to be as similar as possible for the big markets. Because otherwise, guys like me are pushing the companies out from here too early. Certainly, there is a kind of element of Estonian me in here that I still want that the companies, test in Estonia, and hopefully, kind of these technologies can benefit the health in Estonia as well, or Estonian people. But what I wanted to say is that the market trends are not favorable for us. So us as the small country, we have to make extra leap to keep the technologies here and to be kind of in the frontier of using these technologies. Unfortunately, we don't see it today.
I've heard quite a few painful diagnoses today on this stage, but Estonia, it is a country, but it isn't a market, must be one of the more painful ones.
And this is not by me. I'm quoting our ambassador to UK, Mr. Viljar Lubi.
Well, anyway, it's the pain is growing, Rauno, but you wanted to comment. Yeah. Probably not that phrase, but something else.
I had a small comment. We did an interview with our colleagues a few months ago with a data scientist in health policy field. And he said that I have in my head all the models that a policymaker could use in order to make better investments in health policy. Meaning that if you give me 1 million euros, I would be able to say in which programs or in which measures or interventions the state should or could invest. So I think that we have the capabilities of crafting or designing the models we need to make good decisions. But the thing is that every other policy field is capable of doing the same, and there is still competing on the resources of the state. Well, the same could be said in education. The same is in every policy field that policymakers could come together, or analysts are able to say that if you put 1 euro into education, we get 10 euros back in 10 years or 15 years or 20 years. And the trouble is that you have to make the investments now, and there is a lack of resources. And on the other hand, then you have to be really good at prioritizing. And then this is where the models come into play once again, that you should have as a state the models ready. You should have very good data to make quality decisions, and that means that you have to be ready when the opportunity comes to make the investments, to make the good decisions you need in health policy.
Erki, so we're really proud of Estonia's digital achievements. How much of that digital potential is actually being used in practice? Where are we doing well? Where are we actually still far behind others?
You mean in healthcare?
In
or
healthcare,
everywhere?
yeah.
I think in healthcare, we are pretty good at gathering transactional data that helps us as the taxpayers to analyze whether the hospitals try to trick the payer or not. And actually, I think that everything that you see on the timeline, how our IT systems were developed over the last 20 years or 30 years, it is a little bit kind of resemblance how this interaction or relationship between the doctors and the insurer actually happened. So we are very good at measuring what's happening with the patient when the patient enters the hospital door and when he or she exits the door. But we are very bad at gathering the data and analyzing the data. What happens before that? What would be the potential kind of benefit of getting them sooner there? Or what would be kind of the downstream cost savings if this person would get to the treatment earlier? We are not really measuring that, and kind of this is why we see that bang for the buck in Estonia is really good. But if you look at lifespan, if you look at health span, then we are average at best.
So what do we need actually to shrink that huge blue part in that screenshot that we saw
it's super
before?
easy.
Well, give us that easy solution then. Go ahead.
You just have to incentivize the doctors and the clinics to embrace innovation. And they are not. Because several things it has been said. It has been said several times that they are optimizing for maximizing the agreement with the health insurance fund. This is the current system. What do we buy from them? They are maximizing it, and I don't blame them. We are all maximizing what we are being paid for, and even it's worse because if they would innovate today, the health insurance fund in 3 years would audit the books and says, "Hey, you are making profit here. I'm going to decrease the payment for that." I'm a little bit exaggerating, but you get my point, right? So why should any sensible head of hospital do anything there if they know that it is temporary and this money will be taken away from them in 3 years?
They don't have the stick, but they don't also have the carrot.
Mm-hmm.
So your proposal to get moving?
My proposal is to put the incentives into the right place, agree who should be really driving the innovation, and incentivize properly. And moving towards the value-based care by measuring the right results is the very good step to the right direction. Having said that, I think that no country in the world has figured out how to do it properly.
That's an easy task, it seems, to get it right first time in Estonia.
We're a small country, and this is what we are good at, Estonia.
So Rauno, how do you see this situation where the system continues in the same path because the motivation is in place, but we know that the end result is that we're missing €1 billion soon?
I'm not going to repeat what has been said already, but I will enlighten from my perspective, or the perspective of National Audit Office. What we have seen in our audit is that we should invest more in prevention and prediction. And as we say sometimes, which is also in some discussions previously was already mentioned, that we should concentrate on providing the right service to right persons on the right time, so that, as we know, enormous sums of money are going into curative services and not so much into prevention and prediction. But the question is how to turn the tables around and that's a tricky one, once again. I also studied political science, and that's why I am kind of a realist in that sense. The problem here is that it's very hard to sell to politicians that prevention is investments. For the reason is investment, because every moment in time the politician has different proposals from different civil servants and ministries on the table, so that you have to be really good in making your point and in your narratives, as Sven Kirsipuu was telling you about earlier.
Erki, now you said that no one has done it right, but people and countries have tried, right? So who can we actually learn from?
Oh, this is a tricky question. I think that elements can be learned from very different countries. Certainly, if we want to see what can happen if you do things right, is Japan, kind of very old population, very expensive healthcare, but very inclusive. Clearly, kind of this is one way to look at how the extremes of the social trends will shape the industry. To some extent, what we see from the digital world is UK and Germany and recently France, how they have developed very structural reforms and changes, how the digital solutions can be adopted by the doctors.
The Germans are doing better in their digital healthcare domain than Estonians, and also the French.
It's painful, I know.
It's getting more painful.
It is.
As we go forward, so maybe I'll need a glass of wine after all this.
French too. So the reason I'm saying that is that if you look where the money goes in the healthcare, then 50 to 60% goes to the personnel. And this personnel cost is not wasted. And this is used primarily when the doctor or nurse has the face time with patient.
And with FaceTime, you don't mean iPhone FaceTime, but
real
old analog
FaceTime.
world FaceTime.
Real FaceTime. So the real trick is to how, on average, can you decrease the FaceTime? Because this is the only way how, from the perspective of unit economics, you can make things cheaper. Because 50-60% of the costs are related to payroll. And the only thing that you can do it is that you have to persuade three parties, patient, doctor, and the payer, to shift to more online, more technology-driven solutions, so that the easy cases are kind of being pushed to the nurses, being pushed to the technology, being pushed to the AI. I think the technology is there. The technology is not the barrier. We are missing social agreements and social arrangements, how to really promote that. Because from the doctor's perspective, and this was quoted here before, if you would have 5 minutes, what would you do? I would see more patients, right? This is kind of the thinking currently.
Rauno, is our only way out to have less FaceTime with our doctor and perhaps more FaceTime on our iPhone screen with AI or a virtual assistant that, hopefully says the right things?
I hope that technology helps. The question is how much. I've read different articles on the question, and some sources say that in healthcare we should maybe get 5 to 10% of productivity raise with the help of AI solutions. This was a study made by Americans in US 2 years ago. And then again, IMF released just a new report on how much AI could support productivity in the state. And in the European Union, it was only 1%, 1.1 to be more exact. It's heavily dependent on the area of life and also the preconditions. But the thing is that if you want to gain 5 to 10%, which is quite a considerable sum already, of productivity raise, you should invest at least in the start into this technology, then into training, then into data management, data quality, then also into training. And one of my messages today here is that we should also invest into the capacity of state institutions to do all that. I mean that I think from National Audit Office's view, the problem in Estonia is that things take too long to implement. In some reports we have said that we don't need more analysis, we need decisions, we need implementation, and for that we need really capable civil servants, we need civil service which is fit for purpose. I think that the number of civil servants is of secondary importance. What is more important that they are capable of doing what is needed, that they are capable of supporting innovations and making all these nice things that Jaanika was talking about. But in reality, what we see and what signals we get in National Audit Office that the situation with data is getting worse, actually, meaning that it takes more and more time to get the permissions you need as an innovator or a researcher to get data, to connect the data, and so on. This is a real problem in Estonia. We haven't done any audit on that, but these are the signals we are gathering.
So what signals, Erki, are you getting from the field concerning data? And I mean, how big of a problem is that our systems, well, they actually don't communicate with each other? The data doesn't really flow, and how big of a problem is that we actually don't have the data?
Yeah, for me it's very difficult to say because I have only indirect input from our portfolio companies. But I have data point from a year and a half ago, and I think this was confirmed by another startup, is that they took a quote from our biobank and UK biobank. The UK biobank was 4 times cheaper, and everything was set up 2 times faster than our biobank systems in order to kind of get integrated genetic data with the healthcare data. So the market tells me that I think we're a little bit sluggish, we're a little bit kind of outside in, kind of, no, we're not competitive.
When we come back to the screenshot or the data sets, Erki, that you showed, how is Estonia's specialist care budget allocated today? Is it working well, or should we somehow review the model?
You want the full truth, or my view?
The truth and nothing but the truth.
Okay, cool. So 90+% of our special care money, except for medicines, everything related to services goes to the companies, for the hospitals that we call haiglavõrgu arengukava or hospital master plan. So hospital master plan is a document that says that these 20 companies, hospitals are, and this is not a Freudian slip, by the way, they are important for our system stability, okay?
And they're doing it well.
Yes, and this hospital master plan, surprise, surprise, is 1.5 pages, right? Yeah. So one document, 1.5 pages, no one talks about that in our society.
Well, we are
determines,
currently.
No, I'm very brave. The others don't really want to take it out. So 93% of the special healthcare money goes directly first to them because they are important for the system, and then the rest is being distributed among all the others.
Now, why is that a problem if those guys actually do a good job?
If they would. And this comes back to my previous system. I would be very happy if their incentives would be in saving money or introducing innovation. But the combination of these two things is super bad.
So you propose to do what? Open the market or change the incentives or both?
So I'm far from saying that it should be open market because we see what happens in the US. They are putting 3 times more per capita into the healthcare and still getting the same outcomes. So I'm far from saying for that. But I think that opening up to the certain amount kind of clearly would help our insurance fund and Ministry of Social Affairs actually to benchmark our governmental system. Because currently there's no benchmark. There's no benchmark how any unit economics that is proposed by the hospitals would be compared to anyone, because there are only similar companies or similar hospitals that this cost can be compared against.
Rauno, do you see something in that? Is that something that is worth looking into or considering more seriously?
What exactly?
Well, the fact that haiglavõrgu arengukava hospitals, they get 93% of the specialist care. We suppose, as a society, get the best service from them with the best price. Right. Hopefully that is the case, but perhaps we could check that by opening up the market a bit more than this 7%.
Well, sometimes I joke that I work in the Ministry of Truth.
Yes, that is what I expect from you, the truth.
But actually I'm a civil servant and I am not allowed to participate in party politics, meaning that this is a question of worldview to a great extent. But what I can say is that what we need to open up market in some version in the future, or making this hybrid model work better, or finding the best or optimum balance between private and public sector, is that we need a transparent system. We need a system that is capable of procurement. This is very important, that Estonian Health Insurance Fund has the capacity to procure. We need good regulations, and I don't mean that we need much regulation, but we need the capacity to, well, as I said, fit for purpose. Meaning that we also need very good information, and then again we have to speak about the quality of data, as was mentioned earlier already several times, that we have good primary data, but not so good secondary data. And I started with the thought that the micro level and these large visions are not connected well enough. So we need to work on the quality of the system before we can start thinking about how much open market we are going to have. Or best to say is that these steps that I described, what are necessary to make the system run better, are also necessary when you want to open market, and also necessary when you don't want to open market more than Estonia has already.
Dear audience, thank you so much for posting your questions on Slido. What is preventing Estonian startups to scale, a person asks? What state support is needed so we could raise medtech unicorns? I guess, Erki, this is for you.
Yeah, I just want to propose two things. First of all, incentivize the hospitals to cooperate with the startups and test the solutions. And another part of that is that, find the way how the doctors would want to cooperate and help them. Because currently the doctors are so overwhelmed, the shortage of doctors is very much known. So we don't get the kind of the buy-in from the hospitals and from the doctors enough.
I also can comment.
Go ahead.
We need less control of compliance and more innovative and experimental mindset, which is not so easy to accomplish in public sector, because our public sector tends to be published when we get too courageous.
How do you support or finance public healthcare providers to generate high-quality data? And if the HIF only pays for services provided and not for IT development or innovation? Yeah. Who wants to take that?
Pay for results, not for services or not activities.
We have done several audits on the question of quality, or should I say the data quality is a horizontal theme in several of our audits, and we often say to institutions that you should deal with the quality of data in several ways. And currently we have an ongoing audit on the quality of documenting health services. So we are trying to answer a simple question: what should state do in order to make health records more quality, better?
COVID times brought the shift to telemedicine in Europe and globally, so why didn't it stay as a routine practice in a way we have Teams, Zoom meetings, etc.?
Yeah, I think COVID made really clear to us that some elements of the healthcare or some services can be provided online and some cannot. So I think the society learned, both the doctors, the patients, and the payer learned a lot, how to, if needed, provide the services differently. It taught a lot how to pay for these services, but the pressure was too short-termed because not all the systems were aligned to the new reality. And you are right that actually we are not back to the 2015 to 17, but it has been falling back.
Auditor General said in one of our reviews of health policy like 4 or 5 years ago already that this is one of the examples that Estonians have to adapt to, that in the future we will have more and more these kinds of connections. And it's very human that you want face-to-face time with a doctor, but in reality this might be the one thing that Estonians just have to be able to adapt in the future.
And last question from our dear audience, what role can the National Audit Office play in facilitating PPPs in healthcare?
The thing that I haven't spoken about yet today is that in order to innovation to work, you need trust. You need trust between citizens and healthcare providers, between healthcare providers and state institutions, the whole ecosystem. And that is one thing that we can and should do via our audits. Our role is simple. We should ensure that the rules which are in place are followed, and if they are not good rules, we should make recommendations to change them. And this is our role. We put very simply and shortly.
Erki and Rauno, thank you so much for this discussion. Unfortunately, the clock is showing 0, so we have to wrap up this discussion. Thank you very much.
Thank you.
Ladies and gentlemen, we are moving to the end of our event. And the sun is still shining outside, and I'm exactly on schedule. So I can be proud of myself that this has actually worked out more or less. It's time for our last panel, and I'm pleased to invite onto the stage 2 gentlemen who have a great overview on 2 of the main issues that we've been discussing today. One is cardiovascular disease, and I'm pleased to invite onto the stage head of the heart clinic at Tartu University Hospital, Dr. Alar. And the second issue that we've been talking about a lot today is data, medical data. What kind of access do we have to that data? So I'm also pleased to invite onto the stage Andres Võrk, the health economist at the University of Tartu. Alar, perhaps we can start with you. We know cardiovascular disease takes a huge chunk of our money from Tervisekassa, or the Health Insurance Fund. What part of this cardiology care pathway can already be improved, made more effective with digital tools?
Thank you, and good afternoon. And as you said, we are the end. of today. So
the end game.
Thank you for having us, and perhaps it's a detailed question to start with. So as a medical doctor in Estonia, or any medical doctor in Estonia, I always forget the things that other countries are still building up, and are overly critical of the tools we have, or the gaps and tools that we don't still have. So I think previous speakers have said that we have some things that are working exceptionally well in a kind of primary patient care. Would be the national data sets of laboratory data, of images, and of prescriptions. So almost all the data are digital. We have access to almost all of it. And if we have to be critical of something, then it's the user interface applications and ability to integrate these data in real time, if we talk about the patient care level. And then we can be critical of other things later. But if we talk about patient care, then what every aspect of cardiovascular care could be improved with the data already there, if it were available at the moment of care for all the healthcare professionals who are involved in the same patient's care at the same time. We have had these references to different pilot projects by the health insurance. One of them has focused on integrating care in one or another disease and having the patient journey covered by kind of a holistic picture, and all of the 6 in the pilot of this year, or the accelerator, we're talking about needing a data integration platform in real time. So we have most of the data, we can criticize the quality, but the ability to integrate in real time is often missing.
So, Andres, you've heard a lot about data today here. I don't know if you've spent the whole day with us. You have?
Yeah,
wow.
I have been.
Then perhaps an open question for you. What is your takeaway from today, and what would you like to actually criticize that's been said here on the stage, as you're a practitioner who knows pretty well what kind of data we have and how it's been used in policy decisions?
Yeah, thank you for inviting me here. Well, my job is so that half of my time I do lecturing, I teach students, so I'm very happy to be here and talk again. And half of the time I do research, so I'm based on the research, I can then say. First, okay, what hasn't been said here today is that today is International Nurses' Day. Thank you, nurses, for your effort, because that's, I think, the cornerstone of the Estonian healthcare sector. Second, if I talk about data specifically, then, well, I think the first session that we had together with the minister, then there was a kind of they said that, okay, we don't have data to link healthcare data and economic data. And indeed, this is so. And unfortunately, the government doesn't help us here. Because researchers really face difficulties, and policy analysts face difficulties to link the data. And only last month we managed to link, for example, healthcare data and employment data. And now we can answer the questions, what is the effect of cardiovascular diseases on the employment, on wages, and so on.
So now we finally know.
Yes, you just have to ask now me. My students are just writing their theses on that topic. But we had to pay for the government to get the data. They didn't pay for us to do the analysis. Unfortunately, that's the situation that we have in Estonia. But thanks to Statistics Estonia, now it's possible. Yes. So we have more and more data, and that, of course, comes to them when we have the data. Now we are eventually, there's a possibility to do proper health technology assessments, which means we can now see what interventions affect the economy most, where we get gains, yeah? So we are there almost. Although only at the beginning of this year we now approved a new health technology assessment guidelines, and they very briefly only mentioned the societal dimension. But that was exactly, we didn't have access to data that the minister told. But now, eventually, we will have it. So everything will become brighter and more efficient and better in the future.
Well, if only that happened 20 years ago. But I mean, it's good that it's happening now, of course.
Yeah.
So I'm just wondering, when will we see the results? When we will have your analysis?
Well, we have defenses at the beginning of June. Come to the university and you will see papers there. So I think already at the beginning or at the end of next year, yeah.
So before the next budget is agreed by politicians, they already have some input from your students?
If they ask, they can get it, yes.
Well, I hope they do. I hope they do. Alar, now, in your experience, what has been the real clinical value of data analytics or even remote monitoring if we talk about, well, the face time with patients, right? We need to decrease that face time with patients, as we heard. This is one of the ways to make the system more efficient, to use the little money we have more efficiently. Do you have any experience where this has actually worked and worked well?
Not that I share every opinion which has been said from this stage today.
And if you don't, please give your opinion.
Yes, and I joined Estonian civil service 20 plus years ago, and I think I have been passed through the levels of both enthusiasm and disappointment of many people on this stage. So realistically, in cardiology, I think there are the biggest use or potential what I see is probably in predictive modeling. It could allow personalized prediction of risks and personalized communication of them in primary prevention to people who are not yet clinically ill, but it could also improve hospital care because you can predict before things happen which patients are at risk and intervene before, and you can avoid things happening in hospital and people staying there for too long. I also see that probably my imager colleagues need to start looking for new jobs. It's not patient FaceTime, but it's computer FaceTime of medical staff. It will be very fast. That is difficult a little bit because of Estonian language and because of less than 1 million native speakers would be the valid medical scribes that would really do my typing work during patient encounters, and I could concentrate on looking in the eyes of the patient. But this will come. It just is an extra effort for a small country. So, and not only do I want a document out of it, but I hope we will get the structured data out of it, provided not by me typing or our nurse typing this in. So certainly are relatively advanced little things that will free health professionals' time, yes.
Andres, if we think in financial terms, what would be the economic benefit of using data? I mean, in this early diagnosis or to reduce late-stage chronic illnesses where we spend most money?
Yeah, I'm totally technology optimist. So I think e-services, data, they can help a lot. First, of course, increasing efficiency in the health sector. So if we have better data, better overview, we would just reduce unnecessary amount of, let's say, diagnostic services like laboratory services, imaging, and so on, if we just have the data there. Again, I have to say that, again, we have just studying what is the causes of the increase or drastic increase in laboratory services in Estonia. We have a huge increase, and we do it, I think, a bit too much. So, and better data will definitely, I think, economize on there. And second, I fully agree with Alar that making patient pathways kind of more optimal, like do we have to intervene earlier? Can some people be intervened later? That can be done with better data and predictive modeling. We have done predictive modeling of cervical cancer, for example, trying to see what are the early signs that women should be monitored earlier. So there are definitely gains. And finally, of course, let me mention that better data can also build us or let us to do more targeted policies and healthcare policy. And Estonia has had at least 2 very good cases in healthcare policy. Do we have time?
Go ahead.
Yeah, okay. First is, of course, about pharmaceuticals. Yeah? We have this, what's called, what's an English term, this additional benefit if you consume too many pharmaceuticals. Yeah? Meaning that it used to be basically so that before 2017, yeah, people have to apply. Okay, I spent too much money on pharmaceuticals, then I applied, and then I get some refund. Yeah? Now it is fully automized. Thanks to all the e-systems, I go to the pharmacy, they already know how much I've spent before, and I get the refund immediately. Before that, we had only 0.5% of people who got this benefit because they had to apply. Now it is 15% of people who have, some pharmaceutical expenses, then they have it. So, and it's only data-driven, yeah? So that's where we have benefits. Or take dental care, it's the same thing.
So we do a few things well, at least in Estonia. That's good to hear. More coming after your students finish their research. Alar, do we have international examples where big data in healthcare has clearly led to better outcomes? Is there a country or a case that you like to bring out as a good example?
No.
No. Then we can be the first ones.
Whatever we mean by big data, I think the slight problem with this data talk is that we talk about very many things at the same time. Many people mean gadget data. In healthcare, we mean all that we collect in healthcare. Anders means healthcare data plus other indicators of how people are doing in the society. So I would refrain from telling that there's a huge success story in a country or a big region of a country. But I think it comes down to kind of small, wise uses, and it all goes then back to having the foundation and a few very important things done right. And I'm by no means an IT specialist or a data specialist, but even a doctor can understand that you need to use the same standard terminology in calling things in medicine. You need to use the same data standards and some other IT standards to make the foundational parts of the data system interoperable.
That's not happening today.
And then you can do whatever you want. This is what we are talking about today. And I think many people have already told that the level of actually wanting to do something is different in different countries. I think all countries have the strategy currently. You can go to a relevant ministry page in all countries and you will find the strategy. I think ours is from the February of this year. It's all very wise. If you then read it and go to ChatGPT and ask what Estonia should do, what would be the crucial things to do, you get the same answers more or less in the same order. Whether the ChatGPT created it or read it and then provided the answer, I don't know. But it's so clear what you have to do. The question is, some countries would have then the resolve to go and implement it, and others will have a lot of meetings.
Andres, where do you see we have problems with things getting lost in translation, where we haven't actually standardized our data sets in a way that we actually can get meaningful information out of communication between the different data sets? Where does it get lost?
Oh, I'm not an IT specialist, but I understand from the work of my colleagues, what they do is that standardization is a lot of work. To standardize all different data sets, be it data of the health insurance fund, health information system, data that we have on genomics data and so on. And that has taken years to do that. And I think we just are still in the process of harmonizing that data. But yeah, I must admit I'm not an expert on that. Now I lost the main point of the question.
So the question is, if we have a lot of data but it's not readable and we can't actually use it.
Yeah, of course. I mean, as an analyst, the data must be readable, of course. The second thing is, of course, okay, let me perhaps switch a little bit the focus. What Erki Mölder just told us also and showed us that we have that large majority of the burden is related to actually, let's say, people's behavior, yeah? And we know in Estonia that 40% of the, let's say, the burden of the disease is related to actually people's behavior, like majority is alcohol, then tobacco, and so on. So although we talk about a lot of healthcare, I fully agree with Alar that prevention is the key word. But unfortunately, how do we do that already from the childhood? And because Estonian data show, unfortunately, that already in the childhood, children that come from poor families have 30% higher obesity rates. And there is no healthcare there, yeah, that you can intervene. So it means that we have to start prevention at a very early stage if we want to reduce that large burden of disease that we have later.
Would you redesign healthcare funding to reward results and not just the volume of services? Alar.
Yes, I'm sure probably given the data our health insurance, which was previously called sick fund, has had and the analytical capabilities, it would have been possible for quite some time ago to at least try to measure outcomes. Maybe the patient-reported part is added later, but we should be able to understand. Currently, I don't think anyone is happy. Erki was slightly cynical about the 20 companies. I'm a middle manager in one of them, but that doesn't make me less human. I'm not happy at all that I get incentivized for providing a second lab test in 24 hours of a thing that should be measured once in a week, maybe, or a month. Or being not interested financially at all about the case whether I have treated and sent home a heart failure patient, whether or not he or she will have an unplanned next hospitalization within 30 days, no one is even asking. So I don't think doctors are very happy, and I think meaning in medical professionals' work is also kind of diminishing if we don't measure the outcomes. So it will have multiple benefits. First of all, we might find out that we are pretty good, because there are people here, at least were people like Lennart, Riino, Thomas back there, who have been measuring outcomes and quality in different data sets, and we're not doing so bad, so it might give some shine back to the eyes of healthcare professionals. And then if it happens that comparative institutions are providing very different outcomes, well, there could be preferences in buying. Surely we should.
Andreas, what kind of incentives would actually encourage all stakeholders to support a systemic change? Because we've been discussing this, again, for years, but it seems as if things are not progressing as fast as some would like.
Okay, so when we talk about financing, I think we mean two different things, yes? One is how we get the money, and that has been discussed in Estonia. Should it be tax-based, social insurance-based? Should we have more voluntary health insurance? And the second is how we distribute money, yeah? How we pay it. And should it be fee-for-service, like it is currently, or should it be value-based care? I think in theory, value-based care is, of course, a very nice thing. But if you think that most of the diseases are now kind of lifestyle diseases. They span for half of your lifetime. How you measure what is the effect of one particular doctor on my quality of life. So it's going to be really difficult. Of course, Estonia we have data, yeah, and that of course we should try at least. So to try at least, yeah, try to pay for the outcome. Regarding measuring outcome and quality, and that of course is a must. We have to do that. I think because we use public money, it should be visible to everyone to see what is the quality of University of Tartu Clinic, what is the quality of other hospitals. We should be able to compare that. I think that's essential that we should do. Whether we should rely that same data to fund them, well, very difficult. Of course, we have currently also quality indicators that Health Insurance Fund uses actually when they distribute the money. It is kind of indirectly influencing also now, but not much. Yeah. But I don't think okay, another topic is how we get the money, but I don't think we have to open that here, yeah?
Well, raise taxes, of course.
Yeah, of course, yeah. Yeah, okay. But
always
that,
a popular choice. Yeah, well, or measure every person's glass of wines and then tax them accordingly.
Well, we have excess tax on alcohol, which does basically the same thing.
Yeah. So, what is it that we've actually left out from this discussion, Alar, so far, that you were kind of expecting that we would cover today? In this situation where we know that the current system, well, is low on money, and we don't have enough doctors. So what is it that you would actually like to propose as a solution?
Yeah, well, we started with on premise that we have to deal with 1.5 times less money, even in terms of proportion of GDP in Estonia in comparison to the EU average. So first of all, we of course have to convince our citizens that they are okay with getting 1.5 times less medical services in Estonia than in other EU countries. And that's for fact, because I think it has been measured that we provide quite a bit of services per unit of money. So we can, of course, try to target things better, avoid duplicating procedures and useless or wasteful treatments, but this will not be of the magnitude of 1.5 times. In percentage, and then we have the up to 2 times difference in absolute terms of GDP. So I'm not sure that this premise holds. But anyway, inside this discussion, I think that data-driven medicine and a more personalized approach, very technology-based, is certainly possible, and it is cheaper than trying to do the same thing in kind of human powers only. For this, I think we need a lot of discussion with society about, someone said the word trust. And currently, if we're talking about opening up the healthcare data, many people get rather worried. People are worried about losing control of their data if they tick a box somewhere. So I think we can much better explain the value of actually using this data, be it in primary patient contact or in creating new knowledge, what Andres is doing, or creating new products. We haven't had that level of discussion. I think we had quite some publicity around our biobank when it was started and the separate law was developed. But I think there's a generation who has not had that discussion and is much more knowledgeable what can go well or not so well with data. So I think that's a topic that needs to be added to technicalities.
Andres, what is your key message that you would want people to stand up in 5 minutes and take a glass of wine or a glass of water if they actually care about the things that we've been discussing today? I'm going to get wine, by the way.
Well, I think I come back to our first keynote lecture. That was, I think, excellent overview, how health is actually related to broader economy. So I think if one message to take is that don't look at health and healthcare in isolation. Yeah? You have to see the links. And of course, to see the links, you should have data to measure the links. And if you have the data, which we will have soon, as I told you, then we can make better decisions. We can increase efficiency of the sector. We can show the Ministry of Finance that our system is efficient. And then we can also apply for more tax money, I guess. Yeah? And of course, with better data, we can open it to, well, like guys like Erki Mölder over there, please come on, use Estonia as a kind of a base to try out different innovations. I think that's what can we do.
What an optimistic message. We have one question from the audience. Only 16% of CVD are lifestyle-based. Other are metabolic and socio-economic. Many speakers focused on healthy lifestyle, but what about diagnostics and prevention?
I wonder what the metabolic is other than lifestyle. So maybe we shouldn't understand lifestyle too narrowly. So it means how much we move and what we eat and what maybe also air we breathe and many other factors that are influenceable. Healthy lifestyle certainly is a good thing for prevention. And then I think we should go rather personalized, because we have the experience that there's no lack of knowledge of what people on average should do. Move more, eat less, eat specific things, don't eat other things. But it kind of doesn't relate to most of us. So with all the data available, with all the communication tools available, I think we should be much better in personalizing that message. And we have had a few pilot projects, so I have been involved as a doctor there, trying to convince people with very high cardiovascular risk that things should be done. And although I kind of think I'm quite experienced, I haven't succeeded. So at least in Estonia, if we design these interventions in prevention, we should much more listen to people dealing with psychology, social sciences, how to target it, where to target it, and what are the implementation measures for different groups of people. They are not patients. We're trying to prevent them becoming a patient. So I think the implementation and communication part should not repeat the you should not eat or drink or move more. We should be more clever with all the technology available.
So, and this is something that the next and probably the last question from the audience in this conference actually addresses: how data and AI can provide for better primary and secondary prevention, how to incentivize general practitioners to apply such insights. Again, a tricky challenge.
Well, okay, regarding family physicians, yeah. Well, of course, I think there are smarter people now in the audience, I think, who know all these fancy dashboards that our family doctors have on patients, but that collect data on individual patients and already then provide also recommendations what to do with the patient, how to incentivize them. So, okay, we have currently incentive system or GPs, for GPs. If they do more preventions, they do some specific tasks and specific analysis, they are paid more. So we have incentive system there. They also have incentive to kind of economize. I mean, well, we talk about private healthcare a lot, but actually all our family doctors are actually private entrepreneurs, yeah? And half of the money that they take out is not in terms of wages, but in terms of dividends, profits. So they have a huge incentive to actually economize, not to see the patient so often, yeah? So they have incentive to, well, invest into the prevention. So I don't know what else to do. Alar,
for the first question here, how can data help? Maybe you have been talking a little bit in a too paternalistic manner here, and maybe that's one of the problems in our prevention also, that it should be the person, him or herself, to actually should try to hand back the responsibility, at least in preventive medicine, to the person involved. And I'm sure we can do that with a personalized set of data and personalized recommendations. Because this model that, be it GPs, there are about 900 probably in Estonia, cardiologists maybe 100 in Estonia, that they would go out and prevent cardiovascular disease. That's just kind of illusion. So whatever we can do with the data, to give it back, to involve the person, him or herself, that's certainly going to move mountains. We are not going to move the macro indicators of cardiovascular health with specialized or even with primary care healthcare, I'm afraid.
Well, in a way, it's a cheerful message that everyone can now take the power back to themselves and take care of their good health at the reception that is about to follow. Ladies and gentlemen, an applause to Alar and Andres. Thank you so much. Ladies and gentlemen, thank you so much for taking part of today's discussions. Thank you so much for all those questions that you put forward. I'm afraid the last questions on AI and data will be left for the reception that is indeed about to happen. Now, we've talked about a lot of complex issues today, including how to fund healthcare more sustainably, how to turn data into real outcomes, and how to make, well, innovation more than just a buzzword, but instead something that improves lives and actually builds economic value. I think one message came clear pretty well, that healthcare shouldn't only be looked at as a cost, but as a lever for growth and better futures, not to mention better lives that we all want to live, hopefully longer and healthier. Now, the conversation doesn't actually end here, as already noted a few times, and you probably might have heard the glasses being put on the table over there. There's also water, by the way, but also some wine. I'd love to invite you all to continue the dialogue at our networking reception, kindly hosted by the Embassy of Switzerland. And in behalf of the organizers, thank you again for being part of the Swiss Healthcare Innovation Day, and I hope to see you all in a healthier future. Thank you very much.